We're about to get started here with our healthcare panel. I want to welcome everyone. My name is John Nothdurft. I'm Director of Government Relations for the Heartland Institute. I know at my table I was kind of asking whose first Heartland event is this? If I could see kind of a show of hands. So wow, a lot. That's great to hear. I know we do have some friendly lawmakers in the room who have come to a lot of our events. Art Wittich and Isaac and Jenna and others. So I appreciate the people who have come to one of our events. This is the first year we've actually done a regional event on the West Coast. Historically, we've just done kind of one big event. So after this, we are also going to be having one in the Midwest and then one in the South in December. So if you want information about those, let me know. But I do want to welcome everyone here and appreciate everyone coming out for our, I guess, inaugural Emerging Issues Forum West. So this is going to be a little bit different maybe than some events you've attended in terms of the way we have our format. We're not going to have really prepared remarks. It's going to be more of a question and answer driven, almost like a Sunday morning talk show. I definitely want a lot of questions from you, the lawmakers, because we want to kind of get into the issues that are of interest to you in your states, and hopefully we can learn a little bit about what's worked in other states. From people who are on the front lines kind of fighting some of these issues on healthcare and welfare reform. With that, let me introduce my panel. To my immediate right, we have Naomi, Lopez, Bauman.
Yes.
Bauman. She's with the Goldwater Institute. All the bios are in the packet, but they're very well esteemed, all my panelists. Next to her, we have Arizona State Senator Kelli Ward. Welcome. And next to her, we have Christina Herrera from the Foundation for Government Accountability, a frequenter of our Emerging Issues forums, so appreciate you coming as well. I guess I want to kick it off, kind of the big elephant in the room, if you will, with what happened with the King versus Burwell decision. Obviously upholding most of the Affordable Care Act. I guess I want to first open this up to Christy. So as a result of that case and ACA, it seems as though states have very little control over health insurance in their states. What are you encouraging state lawmakers to do to at least try to either maybe fight back against the federal control, or just try to do anything to try to keep healthcare rates down and increase affordability and accessibility to healthcare?
Yeah, well, it's good to be with all of you. I just want to say, how many of you would like to trade John Roberts for Harriet Miers at this point on the Supreme Court? Even though they joke that she would, sign all of her rulings and dot her I's with little hearts and write everyone thank you notes. It's clear that we do have enemies on the Supreme Court, whether or not they're conservative or liberal. And I think both of the healthcare cases that we've seen definitely confirm that. A couple things about King versus Burwell. One thing I want to mention, since Medicaid expansion is my research specialty, a lot of folks have said, well, guess what? Now that King versus Burwell is decided and Obamacare is here to stay and it's the law of the land, Medicaid expansion is going to be a lot easier for states to do. And you might remember that President Obama took like a victory lap. He went to Nashville and to all these other places saying, now this is time to expand Medicaid. I actually think King versus Burwell makes Medicaid expansion tougher for states, because now that the Supreme Court has just upheld Obamacare subsidies for a lot of the people in the Medicaid expansion population, why would you as state lawmakers spend your money to cover those folks? So I actually think King versus Burwell, one of the very small silver linings is that I think Medicaid expansion doesn't become easier, it becomes tougher in the states that haven't done it. So not to depress you all thoroughly at 9:15 in the morning on our first panel, but I think our panelists would agree that Obamacare has pretty much screwed you guys in the states. You have no control over your health insurance markets. Purchasing across state lines, it allows you to do that, but only if all of the states offer the same kind of health insurance coverage. It's kind of like saying, You can buy any car you want as long as it's black and it has 4 doors and windshield wipers and heated seats. I mean, what kind of choice is that? So what you as lawmakers really have to do is look at things that bring down the cost of healthcare. And we're actually at FGA, we have this new initiative called Right to Shop. And it's based on something that the state of New Hampshire is doing with their state employees. So they say to their state employees, okay, you have to go in for a knee replacement, and your knee replacement costs $10,000. If you find another knee replacement for $5,000, we'll cut you a check for $2,500. We'll split the savings with you down the middle. This has saved millions in their state employee health insurance program, and we think that Right to Shop should be available with state employees, with Medicaid patients, and even with people in the private market. So we actually have this very interesting piece of legislation going through Maine. It's Right to Shop, but it's Right to Shop for everyone. And it's this coalition of rural hospitals, conservative folks like us, left of center patient advocates, all saying we want patients to be able to be closer to their health care and to control the cost of their health care, and we think being able to shop around is a good deal. So keep your eyes on New Hampshire, keep your eyes on Maine for this Right to Shop initiative, and if you want to talk further about it or need model legislation, we have that available.
Thank you. Senator Ward, kind of a follow-up. As a state lawmaker, what are you facing in Arizona, and what have you guys tried to do?
Right. Well, you know, as a state senator, it concerns me so much with King v. Burwell in that we are so careful when we craft the language of every piece of legislation, and every word means something. So if the Supreme Court can just throw that out the window, what is the next thing that's going to be thrown out the window? So that is very, very concerning. For me as a physician, it is also very, very concerning because we are seeing, I work in the emergency department in rural Arizona, and I like to say that I see the good, the bad, and the ugly of what's happening with Obamacare and Medicaid expansion in particular in Arizona. And I'm willing to concede that there might be a tiny bit of good. It's very, very difficult to find, but there's a lot of bad and there's a lot of ugly. We have taken people who had private insurance and we have pushed them into the Medicaid market. We have given people a piece of paper to say that they have health insurance but no health care. Mm-hmm. We have not expanded the primary care workforce enough to take care of people who are now thrust into a system that they don't know how to use. Some of the things that we've done in Arizona, because there are a few Arizona legislators out there, Vince and Andy, and so give a wave, guys, yay, shout out to Arizona. We fought vigorously to prevent Medicaid expansion from going through, but we had a couple of big government Republicans who joined with the Democrats and our governor at that time to push that through. So because we were at that point stuck with it, I'm hopeful that we're not going to be stuck with it forever. We did a few things. We added some accountability measures into the Medicaid system. One regarding the use of the ambulance services and emergency room services, because people, you guys probably won't believe it, but I see people, they take the ambulance to the emergency department to get a medication refill, to get a work note for the doctor. They come to the emergency room for things that are not emergent. And for me, in the business, my husband owns an emergency medicine group, which I am very blessed to be able to work for to keep my medical skills sharp. But every time we see a Medicaid patient that does not have a true emergent condition, we lose between $9 and $10 on every single patient. It is a slowly failing business model, and we have got to stop it. So we put those accountability measures in terms of the ER and the ambulance services, and also in terms of people who get narcotics. We have a huge narcotic problem for prescription drugs across the country, but in Arizona and in my district in particular. And so when people shop around for doctors to give them narcotics, our health plans are going to have to look at them, and they're going to have to intervene to put them on the straight and narrow so that we can kind of get that under control. We also worked on the direct pay model. So we had a few practices in Arizona who were shockingly, keeping insurance out of the picture. So they had the patient and the doctor, and the patient was paying the doctor directly without a middleman. And the Department of Insurance didn't like that. They felt like they should regulate that practice. And so we were able to stop that regulation by the Department of Insurance because it was not insurance, and we were able to put that into our business statute. So there's still some consumer protection, but patients and physicians are able to get and provide the care that people need. So there are options out there. So don't give up yet. I think that we will prevail, and we will able to get consumerism put back into the healthcare system so that we can have free market approaches to taking care of people.
Thanks. Naomi, did you want to add anything?
So I think on affordable care implementation on the ACA, a lot of states took very different routes to actually implement the law in their own states. And there's a broad range of implementation that states did. Some states, well, let me step back just a second. There are two tranches of regulations on state insurance markets under the ACA. There were the early market reforms, and then there were the reforms in 2014. So in some states, they actually passed regulations for both tranches of sets of regulations. Some states only passed laws for regulations on certain aspects of those regulations, some on one, some on both, and there's just a big wide range of different ways that the states did it. Some states only issued sub-regulatory guidance, which means that there's no law on the books at this point, and some states, like Texas, said we're not doing any of it. But take a look at what your state did to implement the ACA. And the reason this is going to be very important moving forward is if there is a new president in 2017, if there is another big push to actually repeal the ACA isn't actually going to be repealed in your state if you've got a lot of laws on your books that are regulating the insurance market. So what you need to do is maybe pass some trigger legislation, basically saying that if the ACA is removed, then we would automatically go to the system of health insurance regulation in the state. That way you have some protection. You don't have to go through this big long fight after ACA repeal. You can take a lot of those important steps right now. And keep in mind, there's no need to go back to pre-ACA regulation. You can actually do something better. You can go above and beyond in terms of promoting free market health insurance in your state. Don't just think outside the box. Take a look at a lot of different ways that you could actually reduce the cost of health insurance. That's going to be really important going forward if we do have a change in leadership. I think that some of the other areas of healthcare are actually really exciting right now. So Christy was talking about incentivizing healthcare, particularly for state employees. This is another issue that state lawmakers can have a lot of impact on. That's because the Cadillac tax under the Affordable Care Act, which was supposed to go into effect in 2013 but was unilaterally delayed until 2018, is now looming. A lot of states are going to be facing this Cadillac tax for their state health insurance benefits. And so what you want to make sure of is that your taxpayers are not hit with a 40% excise tax on their plans. That's going to be something that you could do, perhaps a law that says that any Cadillac tax is going to be paid by the state employee and not by the taxpayers. And it's also a very useful tool in negotiating with the state employee unions if you have one in your state and if they're particularly powerful. So that's a lot of leverage that can be used. But at some point, these state health insurance plans will be hit with the Cadillac tax. The reason is that the way that the value of the plan is indexed, it's by inflation, by the CPI, and not medical inflation. So at some point, the cost of these health plans will overtake the threshold for the Cadillac tax, and your taxpayers will be liable if you don't take any action on this. The other area I think that there's a lot of opportunity is to protect and promote health innovations, things like direct care, like Kelli was talking about. Anytime you can protect the relationship between the consumer and the healthcare provider is going to be an important step, because we don't want every transaction regulated. We don't want it regulated as a health insurance product. We don't want it regulated by the government. So anything you can do to corral that off and protect that from regulatory hands is going to be a really important step. The other thing that I'm really excited about that Goldwater Institute is pursuing are free speech in states. I'm not a lawyer, but our litigators tell me that there are a lot of opportunities in the states to actually protect free speech between physicians and pharmaceutical companies, for example, between consumers and health providers. And whenever you take a look at emerging areas of technology like telemedicine, this is going to be a really important area, I think, a new area of research in health policy that I think lawmakers can be really helpful with. If we're able to use state constitutions, which in many cases provide much stronger free speech protections, then we're going to be able to, I think, get ahead of regulation and actually fight it back through litigation if we need to, in order to protect things like telemedicine. And all of these relationships between the consumer and the healthcare provider, I think, will be better protected under these free speech zones. And so that's going to be, I think, one of the next frontiers of healthcare reform for us.
Great. I think those were very good answers and kind of giving some things that states can do. I think a big part of it, as many of you touched on, lawmakers, whether, ACA is here right now, it may, I think many of us, or all of us on this panel, hope that it is repealed or at least rolled back in some form down the road. But states need to prepare for that. I mean, they need to start talking about solutions, free market solutions. We can't just say, well, we don't like, Obamacare or ACA, so let's just kind of just talk about it. We need to start having that conversation, which I think many of us on the panel have kind of laid out some of those things they need to talk about. I want to switch gears from kind of health insurance to pharmaceuticals and drugs. So, Naomi, right to try, this is something that the Goldwater Institute has really pushed. Can you explain that? It's passed in 23 states already. What are some of the lessons from that, and how has that been playing out across the country?
So I'm sure many of you are very familiar with right to try legislation, and many of you have supported it in your states, and we're very appreciative of your efforts. Basically what it does is it allows the patient with their physician and with a pharmaceutical company that has already agreed to allow a terminally ill patient to try an experimental drug, a drug that's already passed phase 1 FDA approval, which means that it's safe. The FDA has already signed off on that. The reason this is so important is because nationally you have so many initiatives that are going forward on right to die. You've got the federal government supporting end-of-life counseling, basically pushing people to save money and die quicker and sooner. And what you don't have, though, is you don't have opportunities for people to save their own lives. And so with right to try, we're not only shining a very bright light on the importance of the individual not having to go to the federal government to beg them, to give them permission to try to save their own life with using a treatment that's already been approved as safe by the FDA, but we're also really, I think, creating a lot more transparency on the system that blocks people from saving their own lives. The FDA is it has so much control over our lives and we don't even know about it. This really brings that issue to the forefront. And I think one of the really interesting things that we're seeing now is that whenever Ebola was such a big threat here in the United States, the FDA was very helpful in getting ZMapp as a treatment for people that had been exposed to Ebola, which is wonderful. We're glad that they did that because that actually saved lives. But this was a drug that was not actually approved by the FDA yet. Meanwhile, the FDA has been very helpful in getting more rapid clinical trials in Africa. So basically, the FDA in this particular case is allowing right to try, but they're denying it to everyone else. And so we're actually suing for information on the process that the FDA used. But this is one example, and right to try is an incredibly important fight in my mind for individual liberty and freedom, and not having to beg the government to let you live, or at least try to save your life. But what it also does, I think, is it really highlights the importance of individual decision making. We're in a new age of information where an individual can find out about clinical trials, they can find out about efficacy, they can find out what is out there, and a lot of patients are now far more empowered than they used to be. So I think 10 years ago this may not have been the case, but today it is absolutely true. It's going to become increasingly difficult for the government to deny individuals access to healthcare treatments because we know about them. We will be demanding them, and I think that is the great news of healthcare reform going forward.
Christy or Senator Ward? I know you guys passed it in Arizona.
Yeah, we passed it in Arizona. I think it's a great opportunity for people to be able to make those decisions. And it's something that we for me as a conservative, I want to fight against collectivism in medicine. Whereas I know that evidence, the evidence-based medicine, is very important. But there's an art to medicine and there's a science to medicine. And while many of us can agree on the science, the art is what comes down to that individual level. And I think that the federal government at this time and the administration that's in charge at this time would like to crush out that art of medicine and say that basically we need to do population science, and if a few people could benefit, too bad for them. I want to stop that. I want to fight for those individuals' rights to live and to try any treatment that would benefit them and extend their life if that's what they would like to do.
Okay, thank you. I'm going to switch because I do want to leave a lot of time for a Q&A. I did have one more question. I know FGA has done some stuff on the food stamp issue, so I want to talk about what you guys are doing in terms of, and maybe how that plays into kind of welfare reform as a whole.
Right, so I know that a lot of you guys have an interest in food stamps. We've seen a lot of legislation in the states doing like drug testing for welfare and food stamp recipients, or limiting the kind of purchases they can make. We've all been in the grocery store where someone has, like Twinkies and Red Bull, and they take out their EBT card and swipe it. Actually, they did an investigation in Maine, and they found their food stamp recipients were mostly withdrawing cash. A lot of them were doing something called bottling, which I'd never heard of. So they would use their food stamp card to buy like cases of bottled water, and they would dump out all of the water once they bought it and then take the plastic bottle in for the 5-cent rebate. I mean, it is, you can't make this kind of stuff up. I think nationally, we all know food stamps have become an epidemic. We're at a record high 48 million Americans on food stamps. The crazy part is the fastest growing group of people on food stamps are able-bodied working age adults, 3/4 of whom don't work at all. They have no reported income. Yes, there are some at-risk families that still take food stamps, but research has actually shown that families versus able-bodied adults take food stamps for a shorter amount of time, and they exit the program quicker. So who do we have to account for this rise in food stamps? It's able-bodied working age adults. So at each of your places, there's going to be a little handout with these dots on it. All of the states have been propagating policies that encourage able-bodied adults to stay on food stamps and waive the work requirement. So is there anyone from Wyoming here? Okay. Wyoming is actually the only state that is the most free market when it comes to food stamps. But as you can see where your state lies on the food stamp kind of grid. If you're in Alaska, Washington State, Oregon, Idaho, Nevada, California, Arizona, or New Mexico, you completely waive the work requirement for able-bodied adults to get on food stamps. If you're in Montana, Utah, Colorado, North Dakota, or South Dakota, you have a partial waiver on work requirements. Now, what can you do to stop this? Well, the Obama administration is part of the reason, a lot of the reason why food stamps have been going up so dramatically. It's because they say to states, listen, if you think you have a problem in your state with unemployment, which is really their cause, you can submit a waiver to us at the Obama administration every year by September 1st saying, for all the people in my state on food stamps, we want to waive work requirements. There are several states that are ending these waivers. Maine did it. They had 25 to 30,000 food stamp enrollees per month before they ended the waiver for work. Afterwards, they had just 13,000 people per month on their food stamp program. Same thing with Kansas. Kansas had 14,000 non-disabled childless adults enrolled in their food stamp. Once they restored work requirements into their food stamp programs, they had 4,500 a month. So really this is so important when you're talking about moving people from welfare to work, from sickness to health to a better life, and off of government programs altogether. Addressing the food stamp problem, I think, is your easiest and best solution.
Thank you so much. Kind of a plug for Heartland, and one of the things that we've put out is we put out a welfare reform report card, which we ranked all 50 states on kind of the other side of the welfare reform issue, which is TANF, temporary, well, it's supposed to be temporary, assistance for needy families.
Is that air quotes? Did you
Air
use it?
quotes, yeah, using air quotes. And actually, the Northwest didn't do very good on that report card. I wrote down some of the rankings. So Oregon got 45th, got an F. Washington State got 34th, a D. Wyoming, 41st, D minus, and Montana got 30th, a C minus. We looked at a lot of different issues. One was, how basically efficient the system is. If you go to one place and you can say, okay, here's your worker who will tell you, here's what you need to get, trying to help you actually get from government dependency to self-sufficiency. And a lot of these things you have to go to 5 different places, all these different things. So that's something we've run into. Kind of the other things that I wanted to actually ask Kelli about, or Senator Ward, you had a bill, probably fairly controversial, air quotes, to reduce actually the time limits down to 12 months. Some people would say that's harsh. We think it's a good step in the right direction. How did that process go? Why did you feel like there was a need to do that?
Right. Well, because just what you said, it's supposed to be temporary. And we've put all of these programs in place to help people who are able-bodied, working age, non-disabled adults to put them back to work. So we've got programs that are funded that are supposed to increase their job skills, improve their ability to write resumes, teach them how to dress, what they need to do, and they've got a whole year to be able to do that. Then we've also got programs to connect them with jobs. And so I have actually been trying to get information from our Department of Economic Security as to how many people are getting jobs, and I haven't been able to get that information from them. How many people are actually getting jobs that are going through these programs that we're paying for as taxpayers, or are they just going to those places, checking a box to be able to stay on assistance? And so that's what we have to strive for, and so putting that year limit on, it's not, it doesn't apply to disabled people. There are waivers available that are out there for people who are taking care of a terminally ill family member, things like that, people who actually need assistance. And I, as a conservative, believe that it is our responsibility as people, maybe not as government, but to take care of those who are unable to care for themselves. The people who are unwilling to take care of themselves, that's a different story. We need to help them to experience the freedom of being employed. And so that's what we're working towards in Arizona.
If I could just add
Sure.
to that really quickly. As I mentioned, Maine restored work requirements for welfare back in 2014, and a couple of things really interesting happened. One, they started getting letters from single moms saying, I would have never gotten a meaningful job had I not been faced with this work requirement, and I'm so thankful for you and this law that allowed me to get myself working again. You can actually go to the Maine Department of Health and Human Services website and see these videos of these single moms. The other thing I think is really interesting, and it's something that came up at one of the NCSL lunches, and someone kind of insinuated, well, are you pushing Granny to work for her food stamps? No, not at all. These are able-bodied working-age adults, as Kelli said, unwilling largely to care for themselves, but it's not just work, it's job training, it's learning the soft skills necessary to work, it's volunteerism. And in Maine, after they instituted work requirements, they actually got a lot of kudos from United Way, a lot of the nonprofits, because volunteerism went way up. So it's not just, if you don't have the jobs available, it's not like you can't impose these work requirements. You can, but just use them in other areas.
I think one of the traps that our side often falls into is getting on the defensive about, no, I do care about poor people. And without really taking a step back and taking a look at what we actually do for poor people. The federal government currently operates, I think, 126 programs that are aimed specifically at low-income individuals. These are needs-tested programs. So the question isn't, do you care or do you care enough? It's, what's the accountability? What are we already spending to care for people? We're already, and I know from certain states that, whenever you take a look at just healthcare programs alone, you might be spending $15,000 per uninsured individual. Are you really getting the value of that money? So whenever we start talking about imposing requirements, let's keep in mind that we already do an enormous amount. If that money isn't delivering the results, that's where we need to be looking. 126 federal welfare programs that are in operation right now, I don't think we're getting much for that money. So we don't need to be talking about, do we care enough? We need to be talking about what are we already spending and how can we spend that better in order to meet those needs.
And one of the problems with that is that the measures of success are different. For us, we measure success as people who are actually getting out of poverty and standing on their own feet. The people running many of the programs, their measure of success is that they spent all the money. And so we have to put those two things together, that spending the money actually leads to the outcomes that we want, not just spending the money and now they need more. So, and that's something that we can do as policymakers to make a difference.
Great. I think now we're going to open up to any questions anyone has. Just, I guess, raise your hand. And
Hi, my name is Ben Sleep from Arizona. Would you clarify on the September 1st, is that if you want to waive, if you're currently waiving work requirements, if you wanted to remove that,
What do you do?
does that require an approval, or is it the other way around?
No, it's the opposite, which is pretty brilliant. So if you wanted to reinstate work for your able-bodied adults on food stamps, you just don't send in the waiver. So it could be an executive action, it could be something you put in legislation to force, your executive branch to do. But basically what happens is September 1st, you notify the federal government we want to reinstate work. October 1st, that goes into effect, and then there's a transition point. So January is when all of the work requirements begin to be imposed.
And I did try to do that this year in Arizona, but I'll be glad to work with you again this next year so we can actually get it through.
I think another point we should mention, I'm assuming it's the same. So, the work requirements for at least the TANF program, it's not that you have to be employed. You have to be actively seeking employment, job training, those types of things. So there's a lot of things under kind of the work requirement, which I think we would all agree if you're working towards, getting learning how to become an electrician. Well, you're making an effort to be self-sufficient, which is really the goal. So this whole work requirement, I don't know, maybe it's a little, kind of misunderstood. So I just want to make a clear, that's the same for.
And we see that in a lot of states, especially with Medicaid expansion. A lot of states have said we want to do a work requirement for Medicaid. So they go to the federal government on bended knee and say, please let us do a work requirement. And they say no. And then the states come back and say, well, how about if we just have people Google for jobs and call that working? And the federal government says no. And so what you see is really like a watering down of work. But there is a strong history of work requirements in TANF, and now we can restore them in food stamps. And then you guys might be asking yourselves, Christy, why should I do something on food stamps? We see none of those savings. Why? I'm going to go through all this effort with zero budget impact for me. But we know what happens when someone walks into a welfare office for one program and they say, oh, did you know you might be eligible for this and for this and for this? And so really what we need to do is to really stop the bleeding, and the work requirements are the best way to do that.
Well, one of the reasons why we put the 12-month limit is because we have all these programs, and so say someone is training to be an electrician, eventually they should get a job as an electrician. So or next year do they go and train to be a phlebotomist, and the next year they go and they train to be something else, and they never get back in the workforce, but they utilize all the programs that are out there. At some point, they need to actually use the skills that they're taking, that the taxpayers have gladly given them, and then put them to work so that they can help other people to get on their feet too.
I think that's the whole carrot and the stick thing. You definitely need a kind of a drop date. Otherwise, they could kind of game the system. So I think that's why the work requirements is important. The sanctions sort of, saying, if you don't prove that you're actually looking for work or trying to be self-sufficient, we're gonna, kind of put some type of sanction on you, and the time limits are all important, and they all kind of work together. Bob?
Bob, why didn't State Budget Solutions? I'm going to give you a little history. Back in the 80s, Washington.
Do you want this? I don't know if everybody can hear.
Pass it on.
Sure. Christy and I can shoot her.
Back in the 1980s, Washington State had a great growth in number of people in welfare. I was in the legislature then. And we noticed one of our counties, Clark County, which is right across the border from Portland, was having a phenomenal growth in welfare. And meanwhile, Oregon was having a decline in welfare. So I went down to look at what the difference was. In Oregon, you couldn't go to the welfare office until you went to the Department of Transitional Assistance and actually look for a job. And when I talked to them, I said, well, what's the big difference here? And they said, the big difference is the voters approved the initiative. The legislature wouldn't do it, the governor wouldn't do it. But part of that initiative was that caseworkers were rewarded based upon how many people they put in jobs. In Washington State, we rewarded caseworkers based upon how many cases they had. So that was bad enough, so I went back home after that, turned on the TV, and here is the Washington State Department of Social and Health Services advertising on Portland TV. You can come to Washington and apply for welfare. There's no wait. So the difference is the incentives really matter. And state employees will adjust very quickly. If you say, we're going to reward you based upon how many people you put in a job, it changes things dramatically.
Yeah, that's a good point.
And I think, one thing to remember is the budgetary impact this has on the most vulnerable. And we've seen this in states that have expanded Medicaid, where they're spending so much on the able-bodied working age adults on Medicaid. They stop heart, lung, and liver transplants like they did in Arizona. And brain tumor coverage, which is what they did in Maine's Medicaid program. So let's make sure that the tax dollars that we do have, let's make sure they're focused on the most needy in our society rather than those that could help themselves.
Any other questions? I think Senator Angel?
Good morning. Kelli, you heard this prior, but in Washington State, I had all written up, ready to run the Right to Try bill. But my concern is, first of all, I want to know if you have any kind of track record on the companies that are developing. It says that they have to be willing to make it available. What are you seeing on that realm? Are they really doing that? I think that my fear was that we would hurt their process, since it's so arduous going through the FDA already, to where we would put a good drug possibly in jeopardy. And second of all, the time amount that it takes. When you have patients that are dying before you can get through the process, how much is this bill going to help? Because I want to do this, and yet I see these 2 points as possibly being stumbling points. So I'd appreciate your input.
So we do, so the reason that it's important to have this law is basically make it voluntary for the pharmaceutical company is that the pharmaceutical companies are, they are in a difficult position, particularly the smaller ones, where they have to use a lot of those drugs for their trials. And so that's why it's voluntary. Not every pharmaceutical company will be able to participate in Right to Try. And that's okay. This is a first step. The other issue is that the FDA requirement for compassionate use has paperwork that basically requires a physician to spend about 100 hours to fill out the application. So most physicians not only don't have 100 hours to do the application, so that's a huge imposition. The FDA has come back and said that they are going to change the length of time that the application, of the required application, down to 45 minutes. We have not seen that yet. They promised it, but we have not. We're still waiting for that. So I guess your question centers around the administrative requirements, as well as can the pharmaceutical companies actually do this? So administratively, the Right to Try in the states does make it a lot easier. You don't have to go through the FDA process where the physician has to spend 100 hours. You're able to do that. The physician is able to do that more quickly and actually help the patient. You can circumvent that. And we also, there's also the concern that insurers may not pay for this, and that's absolutely true. This Right to Try is a first step towards more patient freedom. It's not going to, first of all, it's not going to work for every patient, because every terminal patient may not have a treatment that their physician thinks is a good idea for them. But for those that do, this does provide another option. It does provide more hope for that terminally ill patient. So this is not a silver bullet. It's not going to address every single terminal patient's issues or concerns, and it's not going to be the right fit for everyone. Not everyone wants to do Right to Try. when they're facing the end of their life. So, but I think it's an important first step to getting around this bureaucracy that requires physicians to spend 100 hours filling out paperwork just to have access to something that might save their patient's life. So I would love to talk to you some more afterwards, but just keep in mind that this is a first step. It's something that we don't want to make a requirement on these pharmaceutical companies that have limited resources where they might have to save that treatment for the trials, because some of these pharmaceutical companies produce the treatments in such small batches that they can't spare it, and that's fine. That's a different issue. We want to match up the pharmaceutical companies with the patients, with their doctors, where it might work.
And I think that it actually may help the pharmaceutical companies and the patients a little bit more quickly, because as a doctor, I've seen drugs that come out that are FDA approved, that are being advertised on television, and then they're yanked back because the study population that they were using wasn't the same as everybody in the whole population. And so this gives the pharmaceutical companies and the patients who may not meet certain criteria to be able to participate in a trial the opportunity to try it. So it can tell us if it's very, very effective, if there are side effects that might not show up if we are using a very, very controlled population. And so I think that ultimately it's going to make for better pharmaceuticals more quickly than what we have in the FDA process.
Is there one state model that's working better than others?
So right to try is very new. Illinois, for example, Governor Rauner just signed the legislation a couple of days ago. They will start on January 1st in Illinois, but it's a very new law in a lot of states. There are physicians in 2 states right now that are preparing to use right to try, and so hopefully by the end of the year we will have right to try having been used in at least 2 states.
One other thing on that, I know that in Oregon, I think they restricted it to patients over the age of 18, and to me, I hate to see that, because our children are, they respond so quickly to treatments that are working for them, and to exclude them, it really yanks at my heartstrings. So if parents are willing and physicians are willing to try treatments that could basically allow that child to have a life, I'd like to see it. So as policymakers look at that, I don't think it makes the law better. I think it makes the law worse by restricting it to those only over the age of 18.
That's a good point. I think we had a question over there.
Yeah, Shelley Hughes, Alaska State House, and I actually have 2 quick ones. One for Senator Ward, what you think of concierge medicine as a possible solution, and then Christy, it sounds like the work requirements for Medicaid expansion, we get that shut down from the federal government. Is there any way around it? Because it works for the public assistant, and do you see any solution out of that? And then this is the third one, it is, and I haven't heard anybody talk about this, but I haven't been serving on the healthcare committee or social services kind of things, but what I hear is that when people get on public assistance and Medicaid expansion, and maybe they are working, but they're making minimum wage, they're not making enough, that they will turn down a slightly better job because there's a cliff and it drops off. So as a conservative, I wondered whether it would make sense for us to try to structure some kind of ramp down so it would incent people to take the better job and to continue to improve themselves, so they're not hitting this cliff and they're better off staying in the lower end job because of the benefits they get.
Okay, so you're right. Work requirements in Medicaid are pretty much a no-go from the Obama administration. But the really interesting part is that if you work a minimum wage job and you put in 30 hours a week, so I guess that's full-time under Obamacare now, but that's kind of between part-time and full-time, you actually will be earning enough to be over the poverty level, the federal poverty level, and you will now, thanks to the Supreme Court, be eligible for subsidies in the Obamacare exchange. So even if you did do a work requirement, had it be like TANF, so TANF is between 20 and 45 hours a week, depending on who you are and what your family size is. There would be no one on Medicaid anyway, because they would work and move themselves over the income limit. One thing about the welfare cliff, and I think you're absolutely right, what happens is in Medicaid and a lot of welfare programs is, do I take the extra shift? Do I pick up the extra hour? Because the marginal tax rate, so to speak, on the extra dollar that I'm earning is over 100%, and I'm better off just staying in the welfare program that I have. Medicaid is like that. So the maximum amount of cost sharing that the federal government will let you impose on a Medicaid patient is about like $600 a year. If they were to earn that extra dollar and go out of Medicaid expansion into the exchange, the maximum out-of-pocket cost for that same person is like between $2,000 and $3,000 a year. So the welfare cliff in Medicaid expansion is massive. The problem is that you will never be able to structure the incentives or copays high enough in Medicaid expansion to have that kind of transition down. We have seen so many states ask for, listen, if we expand Medicaid, but we make people chip in, $50 a month towards their health care, CMS says no. They say low cost sharing in Medicaid, and once you leave Medicaid, sorry, you're on your own. And you also have to think about the moral implications of Medicaid expansion. When you're putting hundreds of thousands of able-bodied adults onto a welfare program designed for the age blind and disabled and low-income kids, what that does to someone's dignity, whether or not, if we did have a work requirement, if we did have co-pays, if we put all this free market cool stuff into Medicaid, is all of it worth that? And that's the question that you as policymakers, you need to consider.
And yeah, and the one thing about the co-pays and the federal government's, they tell us that we can be innovative as states, but Arizona, we requested to be able to ask Medicaid recipients who smoked to pay $5 a month into the healthcare system, and that was seen as a barrier to access. Now, if many of the people who smoke are spending $5 or $10 a day on their cigarettes, but we can't ask them for $5 a month because the federal government puts the hammer down and says no. So we, I think, as states have to start standing up to that and really exercising our sovereignty as states and the federalism system to be able to say, come on, this is crazy the way that you're forcing us to run our programs. I'd love to see them just block granted back to the states and let us figure out how to deal with our poor and our disabled ourselves, rather than having the heavy hand of the federal government on top of us. But back to your concierge question. So many of you may not know what concierge medicine is or what's out there, but it's basically a direct pay model. In concierge care, it's generally seen as for the more affluent, the more wealthy people are able to just have a relationship with their doctor, go in and pay for what they need. The direct care system that we have in Arizona in some of the clinics actually is for very low income people, and that's why it's in a very rural part of the state in Show Low. And what they did was basically say, if you are under the age of 45, you pay us $40 a month or $45 a month, and we'll do all of your healthcare needs that we can as a family physician. If you're over that age, then we're going to charge you, $85. And so that's why the insurance industry wanted to regulate them, because they said they basically had their own little HMO, which they didn't. But that allows people who can't afford the subsidies in Obamacare that are so good for them, but they're able to actually get real care, not a piece of paper that says that they have access to care, actual care. The Obama administration kind of frowns on that because it takes people out of their system. It dilutes the amount of slave labor that they have in the system because people are actually going in and getting their care. So I think it is definitely an option, and people have to remember that it's not only for the rich. It actually helps the poor to actually get good care, the care that they want, the care that they need, not the care that the government tells them that they are required to have.
So I'd like to address your question on the welfare cliff. I want to just plug a study that was done by someone named Eric Randolph, who's based in Pennsylvania. This research was done at my previous employer under my research direction. What we had Eric do was take a look at 2 scenario families in 3 different counties in Illinois. It was a single mom with 2 kids, and then we also had him look at a 2-parent family with 2 kids. What he did was he took a look at the entire welfare benefits package that would be commonly available to an individual or family: TAMP, food stamps, EITC, Medicaid, housing, and child care benefits. And what he did was he aggregated the value of those benefits and took a look at what would happen as that family earned more money in those 3 different counties. And he demonstrated the welfare cliff, that a single mom in Cook County, if she went from the current minimum wage up to the new Chicago minimum wage, she would lose basically 1/3 of her welfare benefits package. That was about $9,000. And so what this did is it modeled this for these families in these 3 different counties and really showed that there truly is a very big incentive for individuals not to work more, not to get a better job. And even if they want to, the single mom, for example, would have to go, I think, from $18 to $36 an hour in order to make it really pay off. And so this is a really big disincentive for people who do want to work. We are undermining their ability to achieve true self-sufficiency, and that is why these work requirements are so important. If you can, at the front end, first of all, keep the person off of welfare in the first place, or move them off to self-sufficiency just as soon as possible, you will be doing an enormous amount, not only for taxpayers, but for those families.
Great. I think we got time for about 2 more questions, so.
Thank you all for what you're doing. Ken Ivor, Utah House. I want to follow on the question on the concierge medicine direct primary care. I passed a bill about 3 years ago that specifically excluded direct primary care. We had insurance division, AGs, trying to come after them for selling insurance. So we covered that. So now in our Public Utilities Technology Committee, we're looking at how to combine telehealth, telemedicine with direct primary care. And then I don't know if you're familiar with Senator Pat Colbeck in Michigan. He seems to think there's some kind of a loophole, an opening in ACA that allows for direct primary care to kind of exploit or use it as a wedge into some of the gap populations where we could use direct primary care maybe coupled with telehealth, telemedicine to basically take over and have the exception take on the rule. Who's doing this? Who should we look to? Comments you may have on how to do it effectively. Is it being done anywhere, where and how, and any other comments you may have on that?
I think that the person who's probably done the most work on your particular point is going to be Peter Nelson at the Center for the American Experiment in Minnesota, and I can certainly share his contact information with you after the panel to look at that.
And in Arizona, the University of Arizona has a very, very strong telehealth network across the state of Arizona, looking for ways to innovate in the areas where we are unable to reach people. We've done all kinds of things. We've extended practice rights to the nurse practitioners because, we're sold that, we're going to go to the places where doctors won't go. Well, you know where they go? They go to the population centers where they can actually make money. But with telehealth, we can actually innovate in those areas. And we've done some legislation in Arizona to allow, from the policy perspective, to allow people to be paid for those visits. And so that's something as a starting point that you could do too.
One more.
Yeah, Art Whittick from Montana House. This is more of a comment than a question. To those of you legislators who may have an adverse executive, if you look at your laws, you probably have, your committees have subpoena power. And one thing that we did, we tried to get a number of these reform measures passed. They were all vetoed. We passed them, they were all vetoed. But you'd be amazed at how many workers, caseworkers, are frustrated with the system and were willing to come in and testify with a subpoena. And it set the whole stage for the rest of the session, which allowed us to shift money to verification because basically eligibility is very low, including some of the things Christy pointed out. Essentially caseworkers are being encouraged to just qualify without any eligibility or verification. I would encourage you to use the underemployed oversight abilities that we have in the legislature and when we did this, I had calls every day from people. Everybody knows somebody who's gaming the system. A neighbor, a colleague, a niece. And so I think if we can get some of that knowledge out and let it become public, it's easier to talk about abuse and then it's, we still may not be able to get the law passed or have it become law, but it's rampant and people know it. It's just that many of the people in charge don't want to talk about it.
I think what Representative Whittick is talking about is Medicaid fraud, and it's something else that we at FGA work a lot on with our Stop the Scam initiative, and it's something that actually won the Innovation Award at CSG. And it was pioneered in 2 blue states, Illinois and Pennsylvania. And basically what they said was, we have millionaires and lottery winners, and with apologies to Naomi who lives in Illinois, and you too, John, dead people on their Medicaid programs. And if you have Medicaid managed care in your state, it's not like you're gonna wait for them to show up to the emergency room before you write a check. You are writing a check every single month to the Medicaid managed care company to take care of these people. So what they said is, listen, we're gonna have a screen door in the front, we're gonna check your eligibility for Medicaid against a bunch of different databases, not just the Social Security income database, but what if you have a hunting license that's worth over $1,000? Are you back on your child support? What are your assets? Looking at all of those things to see whether or not someone who is applying for Medicaid should really be there. What happened in Illinois? The bill, Republicans are in a super minority in Illinois. The bill passed with 7 no votes in both chambers. Democrat Governor Pat Quinn signed it. They actually, it was 300,000 fraudulent people kicked off the first year, 200,000 fraudulent people kicked off the second year. And in Pennsylvania, they found, like I said, millionaires or lottery winners in their Medicaid program. So when you talk about doing Medicaid reform, the biggest Medicaid reform you can do is stop the fraudulent folks from sucking all of the resources out of the program so you can use those to take care of the truly needy. And this is something that you will find amazing support on the left with. Seniors advocates, disability advocates know. We have a mother in Illinois that we work with, you might know her, Christine Chalky, who said, listen, my child was never supposed to live past the age of 2. He has a severe seizure disorder. And because Illinois had all of these fraudulent people on our Medicaid program, they stopped covering the one medication that my son needed to live. And so she's our kind of spokeswoman for our Stop the Scam initiative, and those people exist in your state. So if you're interested in model legislation on Stop the Scam, I'd be happy to share that.
And we tried that in Arizona also. We got it through the Senate, but we couldn't get it through the House this time. But I'm more than willing to keep trying. I think that we also have to think about, as policymakers and people who are involved in this, the way we talk about it and where we talk about it. We have to have a paradigm shift in terms of letting people know what's up, and utilizing social media, and instead of just waiting to get an interview on the Sunday talk show or on the news station, getting that word out and allowing the people that we represent to start having the conversation with us and with each other. You'd be amazed at we just had this issue with the wild horses in the Salt River in Arizona, and that thing spun up so fast on social media that I think our entire congressional delegation signed on to a bill about these wild horses. And you think, okay, wait, we've got all these other things that are so important, and we're spun up about that. So we have to learn as conservatives how to spin that up, and some of that involves social media and PR, and we can't shy away from it. We have to get right in there and get in the fray.
Yeah, you're not very active on there at all.
No,
so.
no, never. You can join me at Kelli Ward AZ, Kelli with an I, because I care about the people. So get on there and get in the conversation.
I guess we'll have time for one quick question, and then we're going to go right into our next panel, which is on education. But I thought I saw one over here.
Larry Scott from New Mexico, House of Representatives. It doesn't appear to me that, for example, a single mom with 2 kids and limited skills would have any incentive to get off of public assistance because there is no way that she would be able to earn enough to match the benefits. Can you point to any state policies or best practices that might help, that are in place to help incentivize a person like that to lift herself up and do better?
Well, that's an excellent question. So the way that a lot of these benefits work is that the longer you are on welfare, the more likely it is that you will get to the top of the line for housing assistance, for example. So I think to answer your question, I have not seen that, and it's extremely difficult. As I mentioned, there are 126 federal welfare programs, and you as a state lawmaker cannot easily combine them. You don't have permission to do so. So the really important way to address that, I think, is to keep the person off of welfare in the first place. Do what you can to provide temporary supports that are outside of the federal rules if you need to keep them off of the rolls in the first place, because the longer that they are on, the more benefits they will receive, and the more difficult it will be for them to get off, because then they will be having to make $30 an hour, which is not realistic given someone who has been out of the workforce and probably isn't highly educated. So I think that it's a tremendously difficult problem, an issue to address, but anything you can do on the state level that keeps them from enrolling in the first place, any front-end support is going to be where you would need to direct your resources and time.
I think one quick example of that is cash diversion programs in states for TANF. So this is a way, basically, if let's say your car breaks down and you don't want to go on full welfare, but you need maybe a certain amount of money to fix your car so you can make it to work. There are, I know the state of Mississippi used this during Katrina, and I believe 30-some states have this on their books, which basically allows a person to go to the welfare office, not get on welfare where you're getting a monthly check or things like that, but you can actually get the assistance that you need for the thing that you need. So if it's paying for a hospital bill because or trying to fix your car, so you're not getting kind of entrenched onto the system, but you have some flexibility. So I don't know if your state necessarily has that on the books, but that's one way to not get people.
I have one more thing as well, and being from New Mexico, you have a great Medicaid reform, I think it's called Centennial Care, that you started a couple of years ago. And one of the things you can do with that is work out a deal with the federal government like Kansas did to divert some of the Medicaid reform savings into job training programs. So Kansas, as part of their Medicaid reform, said to the federal government, listen, we're going to be saving you billions of dollars. How about you cut us in on some of that savings, and we're going to use it to find people jobs that are at risk for being on Medicaid, jobs with employer-based health care. And so it's a really interesting way to leverage the public dollars you have now to stop people from coming into the system in the first place. I'm not sure when your Medicaid waiver is up, but the next time you renegotiate it, that's something that I would look at.
Well, that's all the time we have for this panel. Like I said, thank you so much to our panelists. If we could give them a round of applause. As I mentioned, our next panel is on education. We're going to take just a 5-minute break to reset the table and get people mic'd up. So thank you again. And